very glad to present this lecture here. The title of my presentation is Use PGT-A Wisely, When and How. I'm Dr. Xu Yanwen from the First Affiliated Hospital of Santiago University. Here's the outline. First, I will introduce pros and cons of PGT-A. Then, when to use PGT-A. It's for which age group will benefit from the PGT-A. And lastly, how to use PGT-A. First, we need to understand the aim of PGT-A. PGT-A is for increasing clinical pregnancy rate per embryo transfer and decreasing miscarriage rates at the same time. Thus, to increase the amplification of selective single embryo transfer and reduce time to get pregnancy. The indications for PGT-A includes advanced maternal age, repeated IVF implantation failure, and severe male factor infertility, and recurrent miscarriage. And in this presentation, we will mainly focus on advanced maternal age. That is, for which age group shall we use PGT-A. And for the nature of PGT-A, the nature of PGT-A is to embryo selection before transfer, not to improve embryo quality. That's the most important things that we need to understand. The nature of PGT-A is just to select embryos. And the rationale of PGT-A is the high aneuploidy rates in our population. Almost half of the blastocysts obtained from women aged 35 to 39 years were aneuploidy. And this aneuploidy rate increased to about 2/3 of the blastocysts from women aged 40 to 42 years, and approximately 80 to 90% of the blastocysts from women aged more than 42 years. And through the PGT-A, that is the euploidy selection, women likely to increase implantation rate in the first embryo transfer cycles. And PGT-A, however, may result in approximately 20% loss of embryos that might have implanted due to embryo damage in the process of biopsy and vitrification, and the wastage of embryos with misdiagnosis or mosaicism. That is, on one side, we can improve our ability to select euploid embryo for transfer. On the other side, PGT-A may result in loss of embryos to approximately 20%. Therefore, pros of PGT-A includes likely increased implantation in the first embryo transfer cycles, thus reducing the futile transfers. Let's look at the data published in Japan. For women aged 40 to 45 years, about 8,700 live births and 6,900 early pregnancy loss were resulted from 87,000 embryo transfer cycles, mostly single embryo transfers. That means 90% of the transfers were futile transfers. The efficacy of embryo transfer is very low. However, biology of the human implantation embryo is still not well understood. We are facing the problems caused by the mosaicism, and PGT-A, of course, costing and possible embryo damage that I have mentioned, and most importantly, accuracy of testing is still challenging. We have false positive results leading to embryo wastage, and we have false negative results leading to misdiagnosis. Okay, when to use PGT-A? It means which age group shall we use PGT-A? First, let's look at a study we have published in Fertility and Sterility. And this year, the study aimed to evaluate the load of PGT-A in young female patients. And the study group consists of cycles using carrier mapping or NGS. That is, study group includes patients undergoing PGT-N at the same time with PGT-A. Control group consisted of cycles with the same procedure, with the same blastocyst biopsy procedure, but only PGT-N for single gene disease without aneuploidy screening. The average maternal age was 29 and single embryo was transferred in FET cycles. In this retrospective study, we compared the benefits of embryo screening because both groups have the biopsy procedure, both of the groups have the vitrification, and therefore we can only evaluate the benefit of aneuploidy screening in this young women age group. Here's the results, prenatal outcomes for patients with or without PGT-A in the first embryo transfer cycle and significantly difference between the two groups. The likelihood of implantation rate in the PGT-A group, that is the CCS group, is 64.29%, significantly higher than the non-CCS group without PGT-A. And the implantation rate in this control group is 50.38%. And the miscarriage rate is reversed. For the PGT-A group, it's only 3.17%, while in the control group, it's almost 12%. And we all got a significantly difference, even after adjustment for the confoundings. And the likelihood of implantation rate was 1.874 higher, and the live birth was 2.073 times more likely. Through this comparison, through our study in the young age group, we can see the benefit of embryo selections. And we did not detect a significant difference in the cumulative pregnancy outcomes. And here's the data. In the PGT-A group, it's 79.59%, while in the control group, it's 68.8%. And no significant difference was detected after adjustment for confounders. And based on our retrospective study, we can see the benefit of embryo selection. And the euploid rate in our study is almost 50%. That's 1 out of 2 blastocysts may be aneuploidy. And then let's look at a randomized control trial in the young age group patients with and without biopsy. And here's the study published in 2019. It's a comparison between the single best euploid versus single best unknown ploidy blastocysts frozen embryo transfers. It's a randomized control trial. And inclusion criteria include female age less than 36 years with 2 day 5 2BB blastocysts. And 2 arms, PGT-A group controlled 109 cycles, morphology group is 111 cycles. Euploid rate in PGT-A group was 73.4%. It's very high euploid rate in this group of patients. And however, they also detect no significant difference in live birth rates. It's 56.3% versus 58.6%. And they also concluded in young infertile patients with at least 2 2BB blastocysts, PGT-A does not result in an enhanced live birth rate, with the evidence suggesting that the efficacy of PGT-A may be limited by the biopsy. Here's the data. And for the euploid rate, the clinical pregnancy rate is 61.3%. And in the subgroup with euploid transfer, and there's another subgroup with a non-ploidy subgroup, and compare it with the morphology group. And Here's the live birth rates. Here, no significant difference. The author considered since 73.4% euploid rate in the PGT-A group, that is, in this group, it proved that the euploid rate in this population is 73.4%. Therefore, the number of potentially euploid blastocysts would be 81. It's from 111 blastocysts transferred in the morphology group calculated times the euploid rate, 73.4% euploid rate. Then the euploid blastocyst transfer in the morphology group would be 81. And in this 81 blastocysts, the live birth is 65%. The live birth rates of euploid blastocyst transfer would be 93.8%. That's 76 clinical pregnancy. 76 divided by 81. It means that in the morphology group, it's more than 100 blastocysts transferred. And among these 111 blastocysts, there will be 81 euploid blastocysts. Through the calculation of only the euploid blastocysts transferred into the uterus, the live birth rate of euploid blastocysts would be 93.8% in this theoretical calculation. Therefore, the PGT-A results in a 37.5% reduction in the live birth rates, because theoretically it should be 93.8%, and reality is 56.3%. 33.8 minus 56.3%. And lastly, it's 37.5% reduction in the live birth rates. In the previous slides, I mentioned the embryo loss. It's about 20%. And in this paper, it calculates the embryo loss caused by the PGT-A. It's 37.5%. It's amazing data. However, let's look at the randomized trial in the advanced maternal age group. It's a paper published in 2017 by Common Review. And in this study, the author proved that PGT-A improved the prognosis of first embryo transfer cycles. And here's the clinical pregnancy rate per transfer, and the implantation rate here is 52.8%. With no PGT-A is 27.6%. It's a significantly improvement in the implantation rate. And for the miscarriage rates, and here miscarriage rates is 60.54% and 45.8%. Also a significantly difference. And also the shortened time interval for live birth. And however, no cumulative live birth rate difference in both groups, 77% and 33.3%. Lastly, let's look at the STAR trial. And it's published last year. It's performed by Santiago Munné and in 34 clinics and testing in 9 labs. Female age ranged from 25 to 40 years with more than 2 blastocysts. Randomization was stratified by 3 female age groups, that is less than 35 young age group, 35 to 37, and 38 to 40. The main outcome is ongoing pregnancy rate, and the frequency of no euploid of embryos was 8.9% in young age group versus 17.2% in 35 to 40 years. And euploid rate was 48% for women less than 35 and 35.5% in 35 to 40 years age group. And there's no significant difference in all age group. In the ongoing pregnancy rates, it's 50% versus 46%. However, they also only found a significant difference in the 35 to 40 years age group. It's 51 versus 37. So in the STAR trial, it confirms no benefit for the young age group. However, we may get benefit in the aged group. And then in this study, we may evaluate the miscarriage rate. Here, for the young age group, the difference of ongoing pregnancy rates may be affected by the high miscarriage rate in the young age group. The miscarriage rate in the PGT-A group is 11.2%. It's relatively high after euploid embryo transfer. So, which age group can benefit from the PGT-A? In my understanding, it depends on advantage acquired through embryo screening and minus consumption caused by biopsy testing and cryopreservation. For example, in the age group with more than 70% aneuploidy rate, then the embryo, the patient may benefit from the selection because each blastocyst transferred, and she has more than 70% of chance transfer an aneuploidy embryo, and only 30% of chance transferring an euploid embryo. And this benefit may be more higher than the consumption caused by biopsy, mosaicism, and cryopreservation. However, in the young age group, considering an embryo transferred each time, the chance will be 70% euploid. Then the benefit of the selection may not overcome the consumption. That's the benefit of the selection will be deeply influenced by the embryo consumptions. Therefore, I think we need to select an age group patients for the PGT-A. In this group of patients with the high aneuploidy rates, therefore, each time we do the PGT-A, the patients may have the increased chance of transfer an euploid embryo. That's to increase the chance of live birth rates and reduce the time to get a pregnancy. And this benefit overcame the embryo consumption caused by embryo biopsy, mosaicism, and vitrification. So, which age group can benefit from the PGT-A? In my understanding, and the advantage acquired in this age group through the embryo screening should much more higher than the consumption caused by the biopsy testing and cryopreservation. That's the high advantage overweighing the consumption caused by the biopsy and testing. For example, in the advanced maternal age group with more than 70% aneuploidy rate, in each embryo transfer cycle, the patient has about 70% transfer and aneuploidy embryos. Through the detection, through the embryo screening, she may increase the implantation rate of the first and second embryo transfer cycles because we can greatly improve the implantation rate of the first or the second transfer cycles through the embryo selection, through the aneuploidy screening. That is to increase the 30% euploid rate to almost 100 euploid rate in each embryo transfer cycle. It means that in this age group, the patients may got a high benefit after selection. And this benefit is much more higher than the embryo consumption. Therefore, this age group may benefit from the PGT-A. But for the young age group, for example, with more than 30% euploid rate group, that's the age group less than 35 years, for each embryo transfer cycles, the patient has almost 30% euploid transfer, even if she has not the PGT-A. She got more than 70% of chance transferring an euploid embryo into her uterus. Therefore, the benefit from the selection was lower, and the benefit may lower than the consumption caused by the biopsy, mosaicism, and the cryopreservation. Therefore, in this group, the benefit is greatly reduced by the embryo consumption, and then she may not got the profit from the PGT-A. And that's, in my understanding, we should do the PGT-A in the advanced maternal age group for improve the embryo implantation rate and live birth rate in the first and the second embryo transfer cycles. And for the young age group, she may not benefit from this embryo selection. That means that PGT-A should not be used for the purpose of increasing selective embryo transfer in the young age group. Lastly, how to use PGT-A. This year in human reproduction, there's several recommendations published by the ACGH PGT Consortium Group. And we got a good practice recommendation for PGT-A, for the PGT-SR and PGT-M. And in this flowchart shows the basic requirements of an PGT center and also accreditation and quality management in the PGT-A procedures. For the preclinical workup, license for offering PGT may be obtained according to local regulations. For example, in China, we need a license from the government to perform PGT-A, PGT-M, and PGT-SR. The exact definition related to the indications should be determined by each center and the local regulations. For example, in China, we can perform PGT-A for women aged more than 38 years old. However, many centers may only do this in women more than 40 years old, and the exact definition should be determined by each center. And karyotype of both partners is needed before the PGT-A to exclude the possibility of chromosomal abnormalities such as reciprocal translocations. Genome-wide technologies such as aCGH, NGS, and SNP array replaced the golden standard methods of FISH and PCR over the last decades. It means the platform, the PGT platform, you can select aCGH, NGS, and SNP array in these days. And selection of embryos based on sex for social reasons is not acceptable. And it's not acceptable, it's prohibited in China. For the genetic counseling, related to IVF treatment, we should explain to our patients what's the embryo biopsy and what's the cryopreservation. For the genetic analysis, we need to explain the testing method and limitation of the test. For example, even though we use NGS or SNP array, the resolution of our testing is 4 megabase. And for any copy number variation less than 4 megabase cannot be detected accurately. Decision making about which embryos are acceptable for transfer should discuss with the patients, especially when the last embryos was mosaic embryos. And it's a deep discussion between the doctors and the patients. The biology meaning of chromosomal mosaicism and transfer policy in your center, in each center, should be written down, and the possibility of a misdiagnosis and the lasting recommendation for prenatal diagnosis. And this is the NGS results for my patients and for the PGT-A along with PGT-A. And this is the only embryos which allow for transfer after PGT-A. However, the results of PGT-A was terrible. We can see lots of the gain and lots of the loss of these embryos. Since it's the only embryos which can be transferred after PGT-A, then we did the second biopsy. And here's the NGS results. We can see a beautiful euploid embryos results. Therefore, we should be very cautious about our decision, not transferring an embryo. If we did not do the second transfer, this embryo will be abandoned. Basic requirements of an IVF PGT centers. And as we all know, there's a high consumption rate during our PGT-A procedure. It's not causing, maybe it's not causing by the testing. It's more caused by the biopsy and vitrification. Therefore, we need a stable blastocyst formation rate and survival rate after vitrification to minimize the consumption causing by this procedure. The PGT method used should have been previously implemented, tested, and validated in the PGT centers. That's to increase our ability to select the embryos, increase the profit of PGT-A. Appropriate precautions should be taken both to prevent and detect contamination. We need the written SOPs in each PGT centers, and adequate labeling system is needed to match the sample's diagnostic results with the embryo from which the sample was taken. Here's the 7 critical steps where labeling and sample identification should be confirmed from the very beginning, embryo biopsy, to the last step, embryo transfer. To summarize, benefit of PGT-A depends on advantage of screening minus consumption caused by biopsy testing and cryopreservation. Therefore, we need a reliable PGT platform, including biopsy and testing. And this platform is the fundamental to the success of PGT-A. And we need this reliable platform to minimize the consumption of biopsy and vitrification. That's to maximize the benefit of PGT-A. And follow-up pregnancies after euploid mosaic embryo transfer is necessary in each PGT center. Lastly, thank you for your attention.